But I talked yesterday about the neuromuscular junction. Basically, because you know the nervous system controls the muscles, the nerves have to be connected to the muscles. And where they come together is the neuromuscular junction. To send the signal into the muscle, I explained yesterday at the end of the neuron, up here's the dendrites, down here's the telodendrons, neurotransmitter is located, and it is acetylcholine, and acetylcholine is released. Now, I'm not going to go into muscle unit or motor unit, and then all I want you to know from this slide is that, you know, endomysin within, epimysin is the connective tissue that holds it all together. If you get a piece of chicken with skin, if you pull up the skin on the chicken, and sometimes there's that very fine kind of silvery thin membrane, if you pull that, that would be like the epimysin, okay? And there's blood vessels and nerves, and muscles are continuous with a tendon or an aponeurosis. It's basically the muscle fibers start to narrow. Now, this looks like a very complicated step-by-step, but I want you to, you need to know the steps, and I want you to be familiar with the steps to how does a muscle contract and relax. Basically, when the brain detects it needs to initiate an impulse, like I talked about the hot stove analogy. When the brain says to move the hand, it needs to contract those muscles of the hand that's touching the hot stove. The brain sends signals, efferent signals, if you remember from the nervous system, down a motor nerve fiber. Motor, movement, muscle. Motor, movement, muscle. As the impulse reaches the end of the nerve fiber, that little yellow thing on the last picture, acetylcholine is going to go across that synaptic cleft, and it's going to bind to the sarcolemma on the muscle surface, okay? The sarcolemma is like the membrane of the muscle cell. So it goes through the sarcolemma, and it reaches inside the sarcoplasmic reticulum. Inside, it's going to initiate calcium ions to be released. So acetylcholine will go into that sarcolemma, into the sarcoplasmic reticulum. It initiates calcium to be released. When calcium diffuses into those little myofibrils, it's going to start to contract. And the energy to do that is ATP, adenosine trietine phosphatase. You can put ATP. But I want you to be familiar with the steps. So impulse, acetylcholine is released, jumps that little synaptic cleft, binds to the muscle through the sarcolemma, binds to a receptor. Once that acetylcholine binds, it initiates the impulse to move into the sarcoplasmic reticulum, which causes calcium to be released. Calcium causes those muscle fibers to contract, and the energy needed to do that is the ATP. Now, when the muscle is done contracting, what's going to happen is the sarcoplasmic reticulum will move calcium out. Calcium will be pulled out of that myofibril. The muscle contraction stops, and it relaxes to its original length. So remember, I said a muscle is a defined length. When it contracts, it shortens its length. And then when it relaxes, it goes back to its original length. Those are all those little myofibrils that are contracting together. And that's how the muscle moves. That's how it moves the bone. So again, that's in these slides, it's important to be able to identify the steps of a muscle contraction. And when I mentioned yesterday, is there's actin and myosin fibers, and basically the Z line, if you remember I was talking about yesterday, how that muscle fiber, the myofibril, is a bunch, they're all kind of connected. The Z line is defining one, but within the Z line, you have actin and myosin. If myosin's in the middle, the actin fibers slide towards the middle. So they are filaments that are going to stretch back and forth. So a muscle contraction is the shortening of all the individual sarcomeres. So if you're looking here, a sarcomere would be over here. This is a sarcomere. there would be a sarcomere. If each one of those is shortening, the whole length is going to shorten. And that's how we get a contraction. Now, this is how a contraction works in striated muscle. Now, the steps to contraction are very base. And one thing that you can start to mentally connect when you get into blood chemistries, which is down the road, we look at the calcium level in animals, and sometimes animals that come in trembling, or sometimes animals are hyperreflexive, sometimes have disorders with their calcium levels, and disorders with calcium can affect proper muscle contraction. So sometimes in muscle diseases or neurologic diseases, cancer affects calcium. Anything that can affect calcium in our patient could potentially affect the ability to have proper muscle contraction. So anything that's defined as a potential muscle disease, we always look at calcium as well. If I move into, we don't need to know all or nothing or twitch contraction. We're not going to talk about that. We're not going to talk about twitches. I do want you to know ATP is what is needed to allow for muscle contraction. Now, when the body needs to get energy, you basically have catabolism, which is the body breaking down its own stores. So when an animal is in a catabolic state, and maybe you've talked about this in nutrition, they're basically getting stores from the body, not receiving that source from an outside source. Now, when the body stores glucose, the body will store oxygen, and that way, if the animal needs it, it can access that if it's not getting adequate sources from the outside. But basically, I want you to know glucose that is stored in the muscle is called glycogen. Oxygen is stored in the muscles as myoglobin. So if we get to, obviously the body's going to get oxygen from us breathing. The body's going to get oxygen from us eating. But there's definitely times we are, maybe going to go over that demand, or we have to go above and beyond. Then they can get it from the muscles. They can break down glycogen, and they can break down myoglobin. There is a condition when you get into urinalysis where we sometimes see myoglobinuria. That means we have myoglobin in the urine. If we have an animal in a severe catabolic state, cancer, severe malnutrition, there are some diseases that cause an abnormal breakdown of muscle. When the muscle breaks down, that byproduct or that myoglobin is released, and when it's high in the urine, we know that it's being produced or released at an abnormal high rate. Okay, so myoglobin, in a normal patient is used and cleared, but when it's elevated in patients, then we have to look at are there diseases or processes going on that are causing an abnormal buildup of myoglobin. And again, by the time we see things in the urine, it usually means in the body something's happened at too fast of rate, and we're seeing signs. That's why when we do a urine test, there's a little dipstick you guys will do, and there's little different colors on you dip it in the urine, you put some urine on it, and you'll test for like glucose, myoglobin, white blood cells, protein, and then we'll look at what's normal for that patient. So ATP is energy, glucose is glycogen, oxygen is stored as myoglobin. What I also just explained is that aerobic metabolism means that the patient has adequate oxygen to meet the needs. And maximum energy can be accessed from the body. Sometimes we get into what's called an anaerobic metabolism. Anaerobic is without oxygen. Think about when you do aerobics, you need oxygen, you have to breathe, okay? But there are times when, you're gonna put your body above a stress level where the amount of oxygen that you're inhaling is not enough to meet the needs. And then what's happening is the need exceeds what you have available. Then the body's going to get into this anaerobic state. It's getting oxygen without inhaling it. And that basically means it's going to break down stored oxygen. The other thing that we get a lactic acid forming in anaerobic metabolism. I usually tell this story in class, and people, if you work out excessively with your muscles, or you do a very strenuous workout, or you go get like a deep tissue massage. I was in a wedding. I was given a massage. I had never really had one before. And the massage therapist said, you need to drink a lot of water when you get home, or you're going to feel like flu. And I was like, whatever, I'll drink water. I'm not going to go like crazy. The next day, I had chills. I felt so crummy. I literally felt like I had the flu. And I felt kind of like a dummy because I'm like, I didn't listen. But what had happened was that deep tissue massage releases that stored, some of that lactic acid sometimes builds up in muscles. And that deep tissue massage releases that lactic acid, and that buildup of lactic acid is what made me feel sick. So it is true. You should do that if you get a massage. But I want you to know ATP, stored glucose, stored oxygen. I already mentioned, yes, it was just it was a Swedish massage, but my muscles in my back, they literally just did my back and shoulders because they were so tight. But they used not like the stones, but it just was very tense, but it releases, especially muscles that are knotted up, it's going to release all that from you. I talked about shivering because one of the things the muscles do is to produce the heat. Muscles and blood vessels can dilate to release heat, but the thing that I focus on is the shivering. The shivering is obviously going to bring up body temperature. Anything that does this. What's very interesting is in anesthesia, when a patient, normally they're cold during surgery, their temperature is going to drop. That's normal. It's very good for the patient when they wake up that they are shivering, because then by the time they start to shiver, I know that temperature is going to start to increase, because we obviously need to get them back up to normal body temperature after surgery and anesthesia. So the shivering is a good thing. Where you have to be cautious is like if you have a seizure patient, and especially a dog, like if they have 1 2-minute seizure, not a big deal. I'm talking about dogs that'll have many seizures in a row, or they will stay sometimes in status epilepticus where the seizure could go an hour, which is very detrimental to the patient. But we often, after we give Valium, one of the first things we do is take a temperature to see if that temperature is too high. Again, stopping the seizure is going to be our first goal, but anything that can do that is going to increase the temperature. This is showing, and I know we talked about this a little bit when we talked about tissues, but it's talking about the characteristics of the 3 types of muscles. Remember, we got cardiac, striated, and smooth. And luckily, cardiac is only found in the heart. It has these striations or strips, so when they do contract, that actin and myosin fibers are linear, so they constrict and align. They are connected with these intercalated discs, so that's what kind of connects all of the fibers together. You can see the nuclei here, multiple branches fused together. You can look at this picture, you can see the striations. Those are the little discs that hold everything, and there's the nuclei of the muscle cells. Now, we do cardiac next term, but the cells of the heart do not have to contract from an outside stimulus. The contraction is set as a pacemaker. So what happens is all of the muscle cells, it's kind of like a follow the leader. When the first muscle cell in the heart fires, all the others are going to follow. And it will follow a wave. The way that the cardiac muscle contracts is because you can't have a sneeze. You can't have the heart muscle squeeze all at one time. Okay, there's chambers of the heart. There's the atria and then the ventricles and then the vessels. The atria contract before the ventricles contract and push out of the vessels. If the heart squeezed all at one time, blood would never get where it needs to go. So it has to follow a wave of contraction, and it's set at a thing called the SA node. The SA node is the sinoatrial node, and it's found in the right atrium. Okay, so it's very important to understand. SA node, right atrium. It says atrial, so it's found in the atria. Now, it generates an impulse, okay? It fires. It's like an electrical system. When the SA node fires, that impulse follows a path. We go over that when we do cardiac. It follows this path, and all of the muscle cells will follow. And this is how all of the chambers basically are going to contract in a coordinated manner. It has to be coordinated or the heart doesn't work. When this, basically, let me explain. If the heart rate speeds up, it's because the SA node is firing faster, okay? Then every cell is going to go faster. It's kind of like if we were in the building and I put somebody as the leader and I said, we have to leave the building, and that person walked really slow, we would all slow down. If I said you have to keep up and the person leading the line went really fast, we would all speed up. But we're not going to pass that person. The person in front is setting the pace. We are going to follow in a coordinated manner. That's exactly what's happening. Now, the nervous system is basically telling the muscle what to do, except in the heart. The SA node sets the heart rate. It does not need a nerve. Like, there isn't one nerve that connects to the heart and tells the heart what to do. That is the job of the SA node. But I told you, when you have sympathetic stimulation, increases the heart is fight and flight. What this is doing is it is basically following with feedback. Okay, the nervous system does have some impact on the heart, but basically the heart is responding to the need. In sympathetic stimulation, the nerves are going to tell the heart, we need more blood. The SA node is going to fire faster. When we get to calm down and parasympathetic, basically the impulse is, hey, you don't need to beat as fast, it's going to slow down. So we do get speeding up and slowing down, but the SA node is getting feedback from the nervous system. It's not that the nervous system is basically controlling the heart. It's telling the SA node what to do, and the SA node controls it. Okay. Now, smooth muscle is different. Smooth muscle, I'm going to mostly focus on the visceral. And remember, I said, where do you find smooth muscle? They're large sheets, typically in most of our hollow organs, the walls of our blood vessels, and then there's small multi-unit smooth muscles that we'll talk about. Smooth muscle is involuntary. We do not have control over it. The cells have more of a spindle shape, okay? So they're not like those basic lines like striations. You can tell that looks a little smoother. Think of like a smooth wave or something of that nature. They have a nucleus in the center. They're homogeneous, but what they do, these muscles ball up. And the reason they do that is they have, here's a cell, okay, a muscle cell, and then we are going to have actin and myosin filaments, but instead of being like this and going like this, they are in an X formation, okay? Here's actin and myosin, and here's actin and myosin. When they contract, they pull the muscle into like a ball. If you think about, if you have one of those like round little purses or like a satchel, and you pull the strings and you got the circle and then it cinches in the middle, That's literally what it does. But think about the bladder is like a circle. The stomach is like a circle. Intestines are like a circular tube, but all of those organs are typically going to ball up because the actin and myosin are in an X formation. And that's how, so again, when you look at a stomach on an x-ray that's empty or a bladder, it's going to look like a little scrunchy ball. And then what happens is it starts to fill with urine or the stomach with food. It's basically going to start to open up. Then they urinate, those muscles contract back to a ball. Open, contract. But they're not set up like this, they're set up like this. And if this shortens and this shortens, it comes together, okay? So it's like a crisscross. And remember, this is found stomach, intestines, uterus, bladder. Most of the visceral muscle contractions come in waves. If you've ever started to feel the urge, like you have to go to the bathroom, you'll kind of feel like a squeeze, and then it stops for a minute. And then you might feel that squeeze again, and then all of a sudden it starts becoming, as the bladder gets more and more full, the squeezing is going to get more intense. But it's not like it's like squeeze, it kind of like stops. The intestines move like a rhythm. It's called peristalsis. That's a wave-like motion. That's going to follow through the intestine. Now, the way that these, they react to stretching. The bladder is going to send a signal because remember I talked about stretch receptors. All of these organs have receptors, and when they get big enough, they send a signal to the brain, and then the brain initiates a contraction. But it basically gets feedback from the stretch receptor. That's how you stop eating. If you eat and eat and eat, and then all of a sudden you're like, I'm full, that's the brain telling you to stop eating. Your stomach has reached capacity. Squeezing of your bladder, I got to go to the bathroom. Your brain is saying you got to empty it because you're at capacity, okay? Typically in smooth muscle, remember in the nervous system, sympathetic stimulation decreases activity, parasympathetic increases activity. When you have fight and flight, we don't need our bladder, we don't need our stomach, we don't need our intestines. The body needs to divert resources to heart, brain, muscles, lungs. So they're going to borrow resources from these hollow organs. They do not need this stimulation. They're going to send those resources. When we get into parasympathetic relaxation, those resources are restored. Now, the multi-unit smooth muscles are small, is where we mean like small, delicate contractions. The iris and the ciliary body that control the muscles in the eye, your very, very small blood vessels and very small airways. These are all locations where we need small, delicate contractions. And again, they're all controlled by the autonomic nervous system. Your eye, basically at night, it's going to start to dilate to accommodate light. If it's bright light, it's going to contract to minimize light. That's an autonomic reaction. We do not control the size of our iris. That is the brain controlling those muscles. Whoops. Okay. So let me bop into, if there's any questions on that, you can bop in. Sorry, we're going to get into this. Let me grab this. Hang on 1 second. Okay. Now, these are some of the muscles that are on the study guide, okay? In your lab homework, there's obviously in those charts, there's muscles that you don't need to know, but you still need to fill out the chart fully for homework. But I'm going to try to focus on some of the muscles that are more important. Sorry, I grabbed the wrong sheet. Okay. All right. What I want to focus on here is, okay, and again, sorry, I know that some of the pictures weren't great when I tried to upload them, so they might look slightly fuzzy. But the trapezius, which if we look at here, originates on the dorsal neck, and its point of insertion is that spine of the scapula. If you remember when we went over the spine of the scapula, it's a point of muscle attachment. But if you can imagine that it's going to advance or help pull the limb forward, because what happens is these fibers here on the trapezius are basically going to pull towards here. By doing that, you're pulling the scapula up, and by that action, it's going to pull the limb forward. Okay, but now this is a longer strip, and then remember, it's going to narrow into a tendon, and then that tendon is going to attach at the spine of the scapula. Okay, these are the pectorals, and again, remember, they are layered, and we have a superficial and a deep pectoral. If we look at our origin, now this is a cat that's in VD. So this cat is on its back. You're looking right here. Basically, the origin is the sternum. They're going to insert over here at the humerus, the greater tubercle of the humerus. But if you can imagine, what happens is these fibers, remember I said when they contract, they pull towards origin. These fibers are going to pull towards the sternum. This is my humerus, okay? The tubercle of the humerus is going to be pulled towards the sternum. So that means these muscles are adductors. They are going to add the limb back to the body. Now, latissimus dorsi, this is an interesting one. It is primarily, these are the thoracic vertebrae under here, which you cannot see. Some of it may extend a little back, but the majority of the origin is at the thoracic vertebrae. These are going to insert at the tuberosity of the humerus. Right here in this picture, it doesn't quite show that as well, but I gotta find some better pictures. But it's basically going to draw the limb caudal, because this is origin. Wow, my thing got really big there. This is insertion. If these fibers contract, they pull towards origin. If they take the humerus, okay, they're basically going to pull the limb caudal. What does that do to my shoulder? Does that extend it or flex it? Think about it this way, pulling back, if somebody wants to type what the action is at the shoulder, it's a, yes, so the latissimus dorsi is going to flex. Okay. If you think about it, it also provides a little bit of support to the trunk, because think about those going laterally, dorsal attachment, latissimus dorsi. Okay, serratus ventralis, did I take that off? I don't know if I took this, I may have taken this off the study guide. I have an old, oh no, I think it's still on there. Never mind. This one is interesting. This is mostly a muscle of support, okay? So it doesn't have much action on a joint. It's kind of supportive of the trunk. But what I like about this name is, so it has this attachment to the cervical vertebrae right here, okay? So here's the cervical vertebrae. It's going to insert in the dorsal media scapula, basically on the inside of the scapula. It doesn't attach to the outside, it attaches to the inside. But in the name, serratus or serrations, it has a serrated appearance. If you've ever seen a serrated knife, or like a steak knife in your kitchen, and it has those little jagged edges, those are called serrations. So serratus and the serrations point ventralis. Again, a unique serrated appearance is what we're looking at with this muscle, but it's mostly a muscle of support. Let me fix something here. Okay. Sternocephalicus is a naming convention for its origin and insertion. It originates at the sternum. It inserts at the back of the skull, actually at the occipital bone. But if you can imagine, sternum isn't going to pull up to our head. Basically, insertion is going to pull towards origin, and it's basically going to turn the head side to side. So it does cause some flexion of the cervical vertebrae, and it does some lateral movement. And that's sternocephalicus. Now this has various pictures on it. It was mostly to highlight the temporalis and the masseter muscle, but I'm stressing the masseter. Okay, the masseter, again, here's on a dog, and our masseter is going to originate at the zygomatic arch. This is the zygomatic arch, the cheekbone. It attaches underneath, so on the medial aspect, okay? It's going to insert at the mandible. So what it's going to do, insertion is going to pull towards origin, and that's what causes the jaw to move up and down or to chew. So it elevates the mandible, and this is the muscle of chewing. The temporalis does this as well. So the temporalis also is going to aid. If you've ever seen a dog chew, or sometimes you're really chewing, and you see right here, you put your fingers there and you make a chewing motion, you can feel this is temporalis, this is masseter. They will both aid, but the masseter is the primary muscle of chewing. Now I definitely need to find a better picture for this. What I'm focusing on here is the semimembranosus and the tendinosus. These are the muscles of injection, okay? Now, if we're looking at, we've got our gluteal group, we've got, this is a fascia lata. I sent you guys yesterday, there was a variety of videos. I don't want to overload you, but if you have time to watch them, they do a dissection of the hind leg. And it will show that fascia lata, she like lifts it up and she shows some of these muscles. But we've got our sartorius here. We've got our biceps on the outside. But what I'm talking about back here, you have the membranosus and tendinosus. And I'm sorry that that's so faint. I tried to clean that up when I made this, but it didn't work very well. Membranosus is a little more medial than tendinosus. Think M in membranosus medial, but you would grab those back legs, those muscles, and we would give the injection caudally. They also extend the hip. They bend the stifle. They insert here at the tuber ischiae. Okay, imagine the pelvis is right here. The back of the pelvis, that caudal point, is the ischiatic tuberosity. They originate at the tuberosity. They insert at the femur and the tibia. So what they do is they pull towards origin. By doing that, it extends the hip, but it also causes the stifle to flex. So they flex and extend. Remember, I said some of these muscles do both. They'll extend one joint and flex another. But these are also muscles of injection. So they also are injection. I took off deltoideus. I took off infraspinatus off your study guide. But let me mention one thing. Remember when I was talking about the scapula, and I said there was a supraspinous fossa and an infraspinous fossa. There was like those two divots, those two fossas. This is where the supraspinatus muscle and the infraspinatus muscle lie. Now, this is a close-up. The scapula would be up here, okay? Here is what we're talking about when we're talking about the humerus. We've got, you see how these muscle narrows to a tendon, but these are the muscles of the scapula. Sean, so temporalis is like in the cheeks. Your cheek is more your masseter. Your temporalis is up here like caudal to your eye and kind of like that little divot right here. But if you chew and you feel kind of like the bulging of that muscle, that's the temporalis. Masseter is going to be lower than temporalis. Masseter is ventral to temporalis. Okay, one on your list is the triceps brachii. Again, triceps, 3 branches, okay? Brachii, found on the forelimb. Here's the scapula. Here is the humerus. You can see there are 3 different muscle heads or 3 different muscle bellies. They narrow to these tendons. So on our triceps brachii, they originate at the caudal border of the scapula. Here is the cranial border because that's pacing forward. The caudal border is here on the back. They are going to insert at the olecranon. If you remember me talking about your triceps, if people, you know, when you get old like me, and this gets a little, you know, they say one thing you can do is take a weight, and I can do like this, okay? Here's my olecranon. Triceps are 3 branches that narrow to my olecranon, but when they contract, they are going to shorten their length. By doing that, it pulls the olecranon towards the scapula, and by doing that, it extends the elbow. It also, depending on how far it contracts, it can flex the shoulder. Extends the elbow, flexes the shoulder. So again, it's a muscle that does a couple different things. This one is extensor carpi radialis. That's on your sheet. Now remember I said this is a dissection image. How many different muscles are there? Okay, there's a bunch here that are labeled. But if we look at number 1, extensor carpi radialis, this originates at the lateral condyle of the humerus. This bone up here that you can't fully see is the humerus. If you remember, the epicondyle should see is up on the top. That's where it's going to originate. It's going to insert at proximal metacarpal. So if I follow it down, it's hard to see, but it's going to, here's the metacarpals, right? This is the, number 7 is the carpus, okay? The metacarpals are under here. So what it's going to do when it contracts is it's going to pull towards origin, and it's going to extend that carpus. So it's up here, extending the carpus. It's an extensor. Okay. Now this one was not in our PowerPoint from class, but I have to talk about the epaxial group. It's listed on your study guide. The epaxials are the other muscles of injection. And normally the epaxials are made up, it says transversospinalis, longissimus, iliocostalis, and splenus. Okay. You don't need to know those individual muscles. I just want you to know them as the epaxial group. There's some that are called the hypaxial and epaxial. Iliopsoas, psoas minor, longis, quadris lumborum. Okay, between these 2 groups, we call them the epaxials. We kind of group them all together. If we want to give an injection, I personally, when I give muscle injections, I use the epaxial groups. I was an on-the-job trained tech when at the end of my high school career and before I went to college. I went to college a couple years after high school, and I had been working as a tech before I went to school. Now, my boss was very paranoid about us using the back leg for injections. because he didn't want us hitting that nerve. He's like, I prefer you use the back muscles. So I learned early on to use the back muscles, which are the epaxials. And, you know, people feel one way or the other. I think in school, they train you to use the back leg. Okay. Some doctors don't like you to use the back because, well, under here is the vertebrae and the spinal cord. But I'm going to say it's going to take quite a feat for you to give an injection in the back, perfectly get it between two vertebrae, and puncture the spinal cord. So it is very difficult to do that. But the reason I stress these muscles is you need to know these for your injection class. And what your landmark is, when we give an injection, you find the last rib, okay? You can do this on your dog or cat at home. You can go down their back, you can feel their last rib, okay? Right underneath these ribs, it's not on this picture, this is where the kidneys are located. I'm far more concerned about injecting into a kidney than I am about hitting the spinal cord. Because if you put your needle, sorry, my arrow keeps going away. If you point your needle this way, and say this is a little cat, and you inject cranially, you could put it in the kidney. Those kidneys are right up under the vertebrae, up in the dorsal retroperitoneal abdomen. We do that when we do the kidney next term. That's where your kidneys are located. So normally I find the last rib, I go an inch or so caudal, and then what you're going to do is either put your needle straight up and down or point caudal. You never point cranially. And as long as you're behind that last rib, and then on the top of their back, I never go right on midline. I feel for the vertebrae, and then I'm going to go one side or the other. They have two strips going down their back on either side. As long as you don't hit right on top of the vertebrae, you step off one side. Now, you have all the way from the last rib to the wing of the ilium. Now, if this is a 5-10 pound cat, you don't have a lot of real estate. If this is like a greyhound or a German shepherd, or, you know, heck, even my boxer, you know, he's not super long, but from the last rib to the hip on two sides, I've got quite a bit of muscle. Okay. So I prefer personally the epaxial group, unless you have a doctor that's like doing everything in the back leg. But as long as you're careful with your landmarks, you shouldn't damage the kidney, you shouldn't damage the spinal cord. I have sometimes in skinny animals gone to put the needle in, and sometimes I hit bone. If you remember, the lumbar vertebrae have those very wide transverse processes. That's what all those muscles attach to. Sometimes when you go off, and if you put the needle in too far, you're probably hitting one of those processes of the lumbar vertebrae. It's just bone. I mean, I'm not saying it's great to do that, but you're just hitting bone. You're not going to cause damage to the vertebrae, the spinal cord. Okay. So I'm just giving you my 2 cents. You'll go over these muscles, but you need to be able to identify what's in those areas. What I'm going to tell you in this picture is blank. In this back leg, between those muscles, is the sciatic nerve. So your sciatic nerve is what you're worried about in the back leg. If you're doing epaxials, you're worried about the kidney, and we're worried about the spinal cord. Let me go back to one picture here for a moment. On your study guide, we've got biceps femoris and quadriceps femoris. And anything that says femoris, we know is with the back leg. And biceps has 2 branches, quadriceps has 4 branches. Now, I told you the biceps is like your lateral thigh. So the biceps are going to be here. The quadriceps are going to be on the cranial thigh. They're going to be here. Okay, so we got quads in the front, biceps is lateral. You've got semimembranosus and tendinosus here. On the inside of the lower leg, and it's not great on this picture, I'll try to see if I can find another picture, is you have our, we have our gastrocnemius, okay? And I talked about gastrocnemius as being this right here, where the leg cuts off on this picture. This right here is your calcanean tuberosity. The tendon right here that you can feel on us, on your animals at home, is the Achilles tendon. The Achilles tendon is connected to the gastrocnemius. So that gastrocnemius, but it is a long tendon, like you feel tendon. If you follow it up, you'll eventually get to the gastrocnemius, and it runs a little more medial, caudal medial on the leg, but it's lower. The gastrocnemius is lower. Okay, so let me stop there. Let me go ahead and unmute everybody. Do you have any questions?